Hi, everyone. Good afternoon. Just going to give a couple seconds for the attendees to trickle in. Welcome to our February 2025 Lunch and Learn. Thanks for joining us this afternoon. Okay, it looks like we've got lots of people on the call now, so we'll go ahead and get started. Thanks so much for joining us. We just want to start by gratefully acknowledging that our work at BC Children's Hospital Research Institute and the Women's Health Research Institute is situated on the unceded, traditional, and occupied territories of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. And we're very grateful for the opportunity to live, work, and learn on these sacred lands. Today, we have a really wonderful presentation by the Children's and Women's Research Ethics Board. So I'm going to turn it over to Holly and Jenny and Talisa to introduce themselves and get started with today's Lunch and Learn.
Great, thank you. And thank you so much for inviting us, because we want to have many opportunities to interact with the research community. I'm going to be talking about like a whole different array of things today, just because I'm excited to talk to you about many different things. I've tried to arrange it in a way that I think is sensible, but I will begin by just saying, for anybody who doesn't know me, I am Holly Longstaff. I am the new-ish chair of the Research Ethics Board. I've been here almost a year now. I love being chair. I love serving this community. I am an ethicist by training, specifically in research ethics, a little bit of public health ethics. That's my PhD postdoc work, all my professional work. I've been at PHSA for about 7 years. I'm also the Director of Research Integration and Innovation for everybody else at PHSA, now that I'm seconded half-time to be your chair. And I do want to also mention, of course, that Karen Strelendorf, she's not here today, but she's our incredible associate chair. And we have the rest of our REB here who are also going to introduce themselves. And I see you've already done the land acknowledgement, but this is where I'm calling in from. That's West Vancouver. And so many of the things that we're going to be talking about today have to do with trying to be more representative in research, trying to honor people's autonomy in research. Really, I get a telephone call while I'm in the middle of doing a presentation. No one ever uses my phone call anymore. No one calls me. Let's wait for it to be done. There. Okay, so I am calling it from West Vancouver, and so many of the things that we were talking about are trying to address some of the past inequities that have happened in research, making sure that all people have the opportunity to hear about research, to participate in research. We know that notoriously all sorts of horrible things have happened to people in research, especially Indigenous folks, First Nations, Inuit, and Métis people, but others as well have been left as therapeutic orphans. So many of our initiatives that we've been involved in at the REB are attempting to try to do something about and rectify these issues. So with that, I'll turn it over to Jenny and everybody else to introduce themselves briefly and talk about some metrics, and then it'll come back to me.
Hi, everyone. I'm Jenne Prasad. I'm the director of the Children's and Women's Research Ethics Board, and I've been with the board since it began in 2009. So I'm dating myself there, and I'll turn it over to Talisa.
Hi, everyone. I'm Talisa. I'm one of the admin staff with the ethics board. I also have Farron here with me, and we do have Manisha as well. But it's hard to turn the screen. So we're just going to quickly go over a couple metrics for the board. These are based off of 2024. This is just a really broad overview. Within the last year, we did get 376 new applications, and then we did also receive over 3,000 PAAs. Which puts us about second for overall volume for clinical boards within the Lower Mainland. And then within those 376 applications, we did have 15 studies deferred, but we did also have 306 studies that were approved within 200 days, which means that the approval was issued within 200 days of the study being submitted. Next slide. Thank you. So just going over a quick breakdown of some of our categories for applications that we got over the last year. We did break these down into child health, which included mental health, women's health studies, mental health, more adult-based studies, and then anything that classified really under other. And in that, we did notice that we received about 69% of our studies were for child health. Women's health comprises about 9% of that. Mental health is about 2%, and then other would be the other 18% that we see come in. That's about it for metrics.
Great, thank you so much. I want everyone to remember that 3,000 plus post-approval activities when we're going through some of these slides. So I wanted to start by talking about privacy because it always comes up when we're talking about research. It's come up for many, many years. It's been an issue, and in fact, it's very simple. In British Columbia, we have an incredible BIPA privacy law that pertains to your research. It's very flexible, and someone once told me that it's actually at the privacy commissioner's office once told me, just pick a section and follow it. And so when it comes to research, we pick the section that is about research and follow it. And all you need to know is that the section basically says that you have to follow a certain kind of criteria, which is generally understood to mean research ethics board review and approval. So you make sure that it's in the public good and linking isn't going to hurt people and stuff like that. And then if the data are identifiable and you're moving them around, then it needs an agreement. And if you've done those things, then you have done what you need to under the privacy law. The difference, the only other additional privacy reviews we would need is when you're doing something in research that would interact with the health authority systems or hospital systems. So if you wanted to experiment with an app that then interacted with CST Cerner, you'd obviously need to get a privacy review and maybe security threat risk assessment to make sure that nothing was going to blow up. But we only send a handful of studies to the privacy office for review using those criteria. And I think it's a sensible thing. So, and that's the way we've been operating for the last 7 years or so within the PHSA and the way we will continue to operate. I just have a quote that I want to read to you that I wrote. I wrote it for BC Cancer, but it really kind of sums up, I think, popular thinking around the difference between privacy law and bioethics notions of privacy. So when we think about privacy and bioethics and research ethics, it's not an absolute value. It's one of the things that we take into consideration when we're making all things considered judgments. So in bioethics, we say you're supposed to take all relevant things into consideration before you make your judgment. So there's times when it's reasonable to trade off privacy to achieve just outcomes, and there's times when privacy considerations will prevail. And making those decisions requires a multidisciplinary team to consider both the procedural and substantive ethics of a case. So the procedural ethics are doing things correctly. It's like, how do you craft a clinical trial that's properly Health Canada compliant, and substantive ethics, which are the moral values that guide you through your work, which you are the experts in your work. And you need to pay attention to both of those things to achieve just outcomes. So input from the research team and patients is, of course, essential in those things. So generally speaking, when we're talking about privacy at the REB, we're talking about bioethics notions of privacy. Unless you're doing a research study that happens to interact with systems or something like that, then we send it to our colleagues at the privacy office for them to determine what might be necessary. Another thing that you need to do is if you have a privacy breach, it needs to be reported to the REB as a protocol deviation usually, and also to the privacy office. That is just a requirement under the law now. And it is kind of bureaucratic. It's no one's super happy about it. It's what we have to do. And it's really up to the privacy office to determine if a privacy breach ever reaches a level that is, potential for actual harm. I think that's happened like one time in the 7 years that I've been here. It's highly unusual for a privacy breach in research to cause serious risk of harm. And the only way to avoid all these reportings is not to have privacy breaches. So the role of privacy notices, a notice that you might see up at the hospitals or you may not, it's the bare minimum of what we're required to do under the law to notify people about how their data are used. So we're going to use your data without consent to improve our systems, to do quality improvement, to do research, to do all sorts of things. But what you can do as part of members of the research community is to help raise awareness that research is care. We should be doing a lot more than just these privacy notices. We don't want someone when they've been a patient at the hospital, last year, and then they get a text from one of our researchers saying, hey, we have this research project you might be interested in, for that to be shocking. People should understand and feel good about the fact that research is part of care and it's part of the services that we provide to you. So anything that you can do in that area would be great. Our research quality offices have developed all these wonderful materials and pamphlets and videos and all sorts of things that you could put up and start talking to your patients about research. It would be good for everybody. You'll also have noticed that Jenny and I have been pushing a lot of studies out of the REB that are not really research. And we're not doing that because we're lazy. You can see the metrics. We have huge volumes. So a couple extra projects aren't going to hurt us in any kind of way. But the thing to think about with non-research activities is about why they are exempted under the Tri-Council policy statement. Why is surveillance exempted? Why is quality improvement exempted? Why is artistic practice exempted? There's different ethics norms. There's different ethics issues involved that maybe the REB is not the best committee to review them. There's different data access use and disclosure processes under the privacy laws across Canada. So if you put a surveillance study towards us as research and we review it as research at the REB, that can really mess up your ability to access data if it's truly a surveillance project or a QI project. So it's not in the best interest of your work to put it down the wrong path. And also different review processes exist for research and non-research. So I hope you understand that when we're saying to you, like, are you sure you don't want an exemption? Let's look at the PHSA project sorter tool that we created to help us determine that. So the project sorter tool is something that I created with REBs, with Elodie, who many of you might remember, and others. It was part of an ethics needs assessment that I led over, it was a while ago, and it took over a year to do it. And it's a very simple bucket sorter, but it just helps start the conversation about whether or not something is research or not. And it should take a few seconds or a few minutes to fill out. Then you submit that to the REB as you have been doing, and then we make a determination if it's research or not. We wrote a paper about it. This is the kind of research I do in research ethics. So it's published if you want to read all about the ethics needs assessment that went into it, but it is a simple bucket sorter. It doesn't do ethics work. It's just trying to help the REB make a very quick determination with you. So now I'd like to talk to you about ethics theory and reality and trying to close the gap between these things. I was thinking, I only have an hour to talk with you. If I had to whittle it down to just a couple issues, what would I want to chat with you about? And these are the two most pressing issues that I'm concerned about, that I'm worried about. And I think we all need to try to do something about them. The first one is that we all have to make a commitment to empower patients and publics and stop protecting institutions. And we're all doing that in all of our work. The REB's doing that, you're doing that. And really the only people that are charged with protecting the institution are our institutional lawyers, our privacy offices, our agreements people. That's their job. That's all of us should be relieved of that. None of us have to do that job. I'm relieving you right now. I don't have to do that job. You don't have to do that job. But it's very, very hard. And certainly the research ethics world has been heavily criticized by academics and others as becoming this thing that now is about protecting the institutions and is not really focused on participants anymore. That's certainly a common criticism of what we do. And, look, a 50-page consent form is not about empowering somebody. It's about protecting the institution. So it's really infected a lot of parts of our work, and we have to try to let it go and stop doing that and start just centering right on the patients that you all serve. The second thing is that we all have to acknowledge the harms that we actively create by relying on consented data when it's not appropriate. We have the kind of the usual suspects who like to consent to research, who already trust and benefit from the system. And so there's lots of research that shows this, and then everyone else that doesn't trust the system and doesn't benefit from the system typically doesn't want to consent because they look at a 50-page consent form like, I don't want to make of this. People that trust and benefit the system look at a 50-page consent form and say, doctor, should I do it? Because they already trust them and they do it. And so we get a lot of people left out of research for that reason. So if you're relying just on consented data, we all know this, you're not getting the full picture. If you're trying to do learning health system, you can't just rely on consented data. So by relying on it when we shouldn't, because maybe we think we're going to get easier access to data, you won't. Just because it's consented doesn't necessarily mean that you're going to get easier access to data. It means you're not going to get what you really need for your study. And we are actively creating therapeutic orphans when we don't tell people about consent-based studies and when we don't include their research in studies that require examination of the whole population. Research is care. I think everybody that's here would agree to that. And it's more than just an ethics issue. This is a right. This is a legal right in the Universal Declaration of Human Rights that everybody has the right to benefit from science. This goes back to this whole thing that we can't just rely on consent-based data. If you're not included in data, in either in consent-based studies or studies that have waivers of consent, if you or your data is not included, you're left out as the therapeutic orphan and you cannot benefit. People like you cannot benefit in the future from scientific research. And when I say scientific, I mean humanities, social science. Of course, we review all types of research that are REB. And then every research ethics guidance document, including the Tri-Council policy statement, says that no groups can be fairly excluded from the potential benefit of research participation. That's a basic fundamental bioethics notion. And of course, we all know that research requires participation from diverse populations to make findings more generalizable. So it's better science. So anything you can do to try to push this idea, really be really vocal about it, that research is care. You have a right to benefit from scientific research is just, like I said earlier, is going to help everybody. One way that we try to help people exercise their autonomy is usually through consent relationship and consent forums. And I find that this notion of relational autonomy is very, very helpful when we're thinking about different ways to talk about consent forums, to talk about consent, to talk about research. In the past, when we talk about autonomy, you tend to think of people as like little robots, like I'm the same as Jenny, Jenny's the same as me. You give us some information and we absorb it or whatever. And that's not, we know that's not the case. So I just want to read this to you because this is from a very famous bioethics scholar, Sue Sherwin, wonderful scholar from Dalhousie, now retired, and did a ton of research in relational autonomy. So what she says here is oppression permeates both personal and public relationships. A richer, more politically sensitive standard of autonomy should make visible the impact of oppression on a person's choices, as well as on their very ability to exercise autonomy fully. Despite its focus on individuals, standard interpretations of autonomy have tended to think of cells as generic rather than distinctive beings. Under a relational view, autonomy is best understood to be a capacity or a skill that is developed and constrained by social circumstances. It is exercised within relationships and social structures that jointly help to shape the individual while also affecting others' responses at their efforts of autonomy. So there's so many different ways that people's autonomy can be constrained and their ability to exercise their autonomy can be controlled and constrained. Now I want to talk about some other fundamental bioethics notions that I've noticed coming up as chair that are kind of making me crazy. Here's the first one, coercion. We have to be very careful in the ethics world to be careful about our terms and in the privacy world and other areas to really know what we're talking about when we use these terms, because they have specific special meaning. So coercion, what does that really mean? This is so serious. The idea that you would coerce a patient, this is gun to head. This is, I'm going to take something away from you. This is the most serious thing you can do. This is an example of this would be, you either get into my clinical trial or I'm not going to provide healthcare to your sister or something like that. That's coercion. Everything else leading up to that is also important and serious. It's called undue influence. Basically have the same notion in the United States and Canada around this. But coercion is something very special. And if we call everything coercion, if everything is special, nothing is special. If we thought that some of our physicians were actively coercing people within this health authority, this is way more serious than anything that REB could ever deal with. This is very, very serious. But undue influence is also important to consider. So an undue influence might be, you're teaching a course and you want your students to, this happens in psychology all the time, of course, is to experience what it's like to be a research participant, and you get them to get extra marks to do studies, and you can kind of pressure them in certain kinds of ways, and you have to be careful about that and stuff like that. But we have to use these terms very, very carefully and make sure that we acknowledge how special some of these issues are. Another one is this retrospective prospective thing in research. That is not the ethics issue. The ethics issue is a waiver of consent justified or not ethically? It's not retrospective, and prospective is not the issue. This is our REB shorthand, because if the idea that consent is is fundamental in bioethics. It's been enshrined in every research ethics document across the world since the Nancy Doctors trial. Is precious, precious, precious in our field. And if you want to waive consent for you, that is a serious thing that has to be justified. We look for different kinds of arguments when it's prospective or retrospective. Certainly, if someone's standing right in front of you, the RUB would say, well, why can't you just consent them? There might be very good reasons for that. And just because it's retrospective doesn't mean that it should automatically be a waiver. But this shorthand that we use in the REB has now suddenly, it seems to me, has become the ethics issue, and it's not. I have worked with researchers where it was perfectly ethical to have a waiver of consent for prospective research, and times where doing a retrospective study with the consent waiver wasn't permissible. And a really nice example of this prospective waiver requirement would be learning health system research. If you're doing hypothesis-driven learning health system research, which is real time and future and a little bit of everything, of course, you're going to need a waiver to do that, to look at all of the data. So that's an example of where that would be perfectly justified. And there's other examples too. Therapeutic misconception is the last big misconception. It is the misconception I want to talk about. One of my bioethics colleagues says that in research, we're all living in a big therapeutic misconception. All research is optional. But yet the way that we are writing these protocols, and I understand that it's because of the way the templates are and different requirements and things like that, we say we're going to do this and this is optional and this is mandatory. It's all optional. It's kind of it's the wrong language to use for these kinds of things. And I worry that because the language isn't as accurate as it should be, that now maybe you're not doing what you really want to do in your research studies, and you're putting things as optional because you think they need to be or something. I wish that researchers could just start by saying, this is what I want to do. You don't have to make everything optional, all these little buttons to click and everything like that. What do you need to do? What's tied to your research objectives or not? And that's what you present to the Research Ethics Board, instead of just going down this funny kind of route. So there's the next thing I want to talk about is consent forms. Operationalizing autonomy that's typically how we operationalize autonomy is through relationship consent forms. There's so many different ways to consent people that are perfectly permissible. I listed a whole bunch here. And then in Indigenous-led research, there's also community consent as well as individual consent, and there's special substantive and procedural ethics norms there to be mindful of. But the point is that unless you're doing a regulated trial, you have just tons of flexibility available to you. If you're doing a regulated trial, the flexibility is it's not the same. You don't have a lot of flexibility. So when you have like high risk clinical research, regulated clinical trials, you have to meet Health Canada requirements, and we have our amazing research quality experts that we defer to help us determine how that is best done. But everything else, lots and lots and lots of flexibility. And it's really hard then when you're in the non-regulated environment under the Tri-Council policy statement and the privacy law, what can you properly omit? And there's been so many research projects over the years. I've been involved in them. My colleagues here at the RB have been involved in them. Everybody's been involved in them. Everyone's written papers about it. No one understands these long consent forms. Nobody likes them. Researchers don't like them. RUBs don't like them. Participants hate them. And so there's been lots of projects and incredible initiatives to try to do something about it, and they all fail. And they fail because they're research projects. And so what we need is for one of the funders to say, nope, we're going to do mandatory short consent forms now. We're going to take a position on this. And that is what the CIHR Ethics Office has done together with Canadian Critical Care Trials Group. It's an initiative that started, I guess, a couple of years ago. I'm involved with it, as are other members of your REB. And we also have an advisory, but we're part of the core writing group. And the point of it was to create a mandatory short consent form that CIHR is going to require across Canada. And why it's important that it's mandatorily short is that it's going to aid comprehension. It's going to lend itself to lots of different methods of communication. Being translated should be much, much easier if it's just a couple pages long. There's not going to be an adolescent assent form. One wonderful scholar in this world, in the world of bioethics, Bartha Knopper, says that everything should be an assent form. If what we're supposed to be doing is grades 6 to 8, that's what we're required to do, even for regulated trials, then everything is an assent form. Why do we have all these forms? Why do we have a parental this and this and this and this? And even what Health Canada says on their website is that there should be, a consent form, either parental consent or whatever, and then a very simple assent form for someone that, a very young child, for example. So that's what the form is going to be. And whatever you need to call it, you can call it a parental consent form or a consent form or an adolescent assent form, whatever's right for you. And then you can create a simpler assent form as well. But that is coming imminently. It's going to be published, and that's going to be kind of the big splash about it. And then if you want to start using it now, you can reach out to me and have a couple of my researchers testing it out right now. I hope you like it. But the expectation of the CIHR is that people are going to experiment with more creative ways of communicating research information in the consent form. So I hope that you will do that. And it was part of a big, huge process that you can read about or I could talk to me about. And it's actually the second initiative. The first one was to create MinSpec's core elements of consent forms for genetics and genomic studies. So this one, that was again another 2-year project that we published in CMAJ. And it was to prepare ourselves for the National Human Genome Library. And there was a lot of concern from CIHR, Institute of Genetics, at that time that we have all of this whole genome sequencing going on, and then we can't agree about what is allowed to be shared, what can be shared internationally and all that. So they asked us to create a MinSpecs, which actually wasn't, it was difficult, but it wasn't as difficult as this last project. But there's so much common ground between all the big sequencing centers. And we were able to come up with some core elements that the community liked. Those are the elements that you need to meet on your consent forms to be able to go into the National Human Genome Library. And when we published this one, did a very big response to show how needed these things are. So it's been viewed in full over 8,000 times. I just checked. By comparison, my ethics paper about our ethics needs assessment in the PHSA project sorter tool was viewed just over 100 times. That's still pretty good for research ethics though. But so this was a big paper for us and for me. And it goes with the mandatory short consent form that's coming out, because the mandatory short consent form in it, you just have to make sure you say these couple of MinSpecs things in there if you're doing whole genome sequencing, and then you'll be fine. It also refers, this new form that's coming out also refers to the HDRNet Canada, Health Data Research Network Canada. We worked on that for over a year to create mandatory language. If you want administrative data from one of the big holders across Canada, so Pop Data BC, ICIS in Ontario, all the big administrative data holders, they all agreed that if you say this little thing in your consent form, that you can use their data with consent. So that can be, if you want administrative data, that can be popped into the mandatory short form, and you're covered. So if you're doing whole genome sequencing that includes administrative data and CIHR funded, you can use this form. The one exception is going to be sponsored trials. And that is because consent forms are about protecting the institution, and we have no business case to tell these sponsors that they should be using this mandatory short consent form. These consent forms protect them from liability and all sorts of things. So if CIHR wants sponsored clinical trials to use this mandatory short form, then they're going to have to build a business case for that. And they're aware of that. They have their quality improvement people working on this project as it rolls out. And hopefully business person will build a case for the sponsors and show that this might actually be better for them and get better representation and whatnot. Just about data now. So I know that news is a little bit grim right now, and there's lack of resources and stuff like that. And I'm sure and there's all sorts of things going on. I don't even want to start talking about it, but I know that researchers have expressed concern about data access and how everything that's happening in the world is going to affect their research and their patients and their participants. And I just want to remind you that there's lots of different ways for you to access data. It's not always fast, but there's lots of different pots of data out there for you to explore. You know, we have the Health Data Platform BC. There's the Panda platform within the PHSA, which is trying to work towards supporting research. There's data registries. We have all sorts of registries across the PHSA that are also available for research. There's research registries that you folks have created. There's ministry data available for research. There are some kinds of research that the ministry holds that requires an extra review. So there's the Data Stewardship Committee, which is established under the eHealth Act. So if you're asking for certain kinds of data like PharmaNet data, you have to go through their review in addition to REB review and stuff. But there's lots of data available for you. There's also these other wonderful repositories of data that I'm not sure everyone knows about. There's CanPath. This is incredible collection of data out there. That's their website. As I had mentioned before, Health Data Research Network Canada has administrative data. They're trying to move that administrative data across Canada and link it with other things that in ways that are pretty exciting. There's CancoGen, that I'm the chair of their DACO, the Data Access Committee. There's lots of whole genome sequencing in there that has been considered in a very broad way for lots of different uses, and there's virus data as well. There's also Indigenous collections of data that they govern, and they're wonderful, and they respect OCAP and Indigenous data sovereignty. And I would invite you to visit some of these data repositories and see if, and of course there's CaiHi and other things as well. Last couple of things I want to talk about is value neutrality. I think, you know, things are very difficult right now in a lot of different ways, and I know at the REB we see a lot of complexity, and really exciting research that you're doing, but it's complex and stuff. And one thing that we know about in research is that inaction is not value neutral. So if you do this, good or bad things can happen. If you do that, good or bad things can happen. If you do nothing, good or bad things can happen. So there's no safe place to be. You have to act. You have to act, making all things considered judgments and learning from your mistakes and stuff like that. So we're trying to cope with artificial intelligence and all of these things that are being thrown at us, and we're not always all going to get it right off the start, but we're trying, and we rely heavily on our research community to try to help us make sense of these things. Collection of final thoughts, and then we can move into some questions. There is for those of you who are interested in working in artificial intelligence, there is a PHSA AI and research working group that supports research, and it supports the REB as well. So maybe some of you don't need like this kind of assistance. Maybe some of you would like to come to this group, present your work, and think about how you might access those data or how you might do this research in the best possible way. And they work as to kind of support the REB. I would invite you to go, well, I'm sure we'll make these slides available to you. There's a link there that you can go and learn about us if you don't already know about us. And then there's a wider AI initiative going on at PHSA under the AI Secretariat. Please go there to see what's going on at the PHSA in artificial intelligence, but it's all moving very quickly. If you think that anybody has it locked down about how to deal with this in the best possible way, no, I don't think anyone does. We're all trying to figure it out. So please be patient. I also want to say that we have some surveys that are going to be coming out. So one of the things that we want to do at the REB is have, you know, it's great to be able to connect with you in this kind of way, although I can't see anybody. And we'll have some questions and answers after. And of course, you know, we meet with researchers every day of the week. That's a very small sample. And so we want to send out some surveys so we can get some feedback from you about how we're doing and how you're doing and what we could do better and stuff like that. There's some REB surveys that my mentor, Michael McDonald, created, and he's one of the people who wrote the Tri-Council Policy Statement, and he worked on the CITR networking group with people like him for many years, and they developed these wonderful tools for surveying the research community and ethics boards and participants. And I looked at them the other day and I talked with Michael, and they're still as relevant today as they were back then. And so they just need a little bit of updating. It would take 3 minutes for you to fill out. So I hope when you see a survey come out from us, you'll know that it was a thoughtful survey, that that people spent years developing. We think it's worthwhile, and I hope that you have 3 minutes to set aside to just let us know how we're doing and how you're doing. Another thing that's coming out, another survey, again, 3 minutes, is anybody that was part of the research roadmap initiative that I was leading with Kai that's the collection of race, ethnicity-based and Indigenous identity data. So we had that event last year that Kai came in and presented at about their standards that they spent years creating. And then our research leadership committee has endorsed that now it's voluntary, but they have endorsed that as a good standard to use to collect race, ethnicity, and Indigenous identity data. And now that almost a year has gone by, we're going to be sending out a survey that's 3 minutes. And it's basically saying, you know, how could we provide you with now that you are using these standards, presumably, is there any education or other kind of things, resources that we can provide to you to help you in this particular area. So look for that survey. I promise, like I said, 3 minutes. I promise that the one coming out that's an evaluation is 3 minutes. Please take the time to do both of them. The last 2 things I will say is, please do not self-censor. Please tell the REB what you really want to do. We have incredible research ethics board members. They're your wonderful colleagues. They can cope with anything. You know, present what you really want to do. Don't try to guess at what they're never going to let me do that or whatever. Present it. We can handle it. And if you're doing something that's really novel, I would say, and researchers have done this, come to the REB. If you think that it's going to be confusing for us to read on paper, unfortunately, a lot of this is just paper back and forth. Come and present to us and say, look, here's what I'm doing. Here's why I think you might be concerned. Here's how I'm dealing with it. Please do that. We love having people at the Research Ethics Board. And the last thing I want to say is be as future-proof as humanly possible in your protocols, in your consent forms, please. I would love it if we could do something about these 3,000 post-approval activities. They're all required. I talked to someone who is a couple of people who are connected with what's going on at the federal level with the Tri-Council policy statement and asked, or should we expect any exemptions coming, or are there any maybe creative ways that we could be compliant with the Tri-Council policy statement? And they said no. So we are doing what we're required to do under the REB. One way to help us eliminate and reduce some of this volume about is to be as future-proof as humanly possible, so you don't have to constantly keep changing things. So I would just ask you to think about that. And the template that's coming from CIHR is quite future-proof, especially the way it talks about confidentiality and privacy. That's some of the things that hang people up and require amendments over time. But that is my last slide. And I'll stop sharing now, and then we'll open it up for questions. And you can ask any of us anything. None of us is made of sugar. You can say whatever you want, and we will respond to it as best we can. See, there's questions in the Q&A in the chat. Where do I begin?
Matthias has asked if you could share a link. I think that original poster that you had, Holly, that was about Research is Care. I will say, Matthias, I noticed a very old BC Women's logo on there, so we may want to revise some of the content before we circulate. And I don't know, Holly, if you want to mention maybe the link to the Right to Participate initiative and Research is Care at the CW campus.
Yes, that would be a great place if anybody's looking for these Research is Care materials and trying to raise the profile of research everywhere. I think if you just search right to participate, it should come up. There's a website at Children's, the website at Women's that's special for each of your communities. There's materials there. There's people you can contact. I'm part of that. The REB has always been part of that initiative, and just to be clear about thank you, Matthias. Just to be clear about the right to participate, I've heard a little nervousness from some researchers that say, well, what I'm doing is working. Why are you doing this thing? Don't use it then. Don't don't use it then. This is one more offering. If you have a consent to contact registry that works for you and you like it, do it. If you have a cold contact process that works for you, do it. Circle of care, no one's touching it. This is another offering that, because we are all part of one legal family at the PHSA with the right to participate. So that's everybody. That's BC Cancer, Children's, Women's. We're all part of one legal family. And you're part of the legal family as a researcher, and the patients are, we can contact them using certain processes. So even if you wanted to contact patients over at BC Cancer, we could figure that out. Or patients over at BCH, because they have a process too. Just one more offering, not replacing it. No, you don't have to use it.
The next question is from Travis. Would an investigator-initiated trial be able to use the short consent form because they are also the sponsor?
Yeah. The one thing, look, I don't want to get in the research quality people's business. Like, Health Canada regulated is a whole different kettle of worms. It's very not a lot of wiggle room there and stuff like that. So I would say you check with the research quality office there. But yes, the intention of CIHR is that the only exemption really from it that they just made very, very clear is sponsors like Pfizer. We cannot expect for sponsors like that to adopt an untested thing that we think is theoretically going to be good based on bioethics literature, and so that's ridiculous. The business case has to be made, and their lawyers have to look at it. So they are the exemption. But yeah, if you're doing a clinical trial that it's investigator led, there's no reason why you shouldn't be able to do it if the research quality people say it's okay.
And then I think the only question was from Siobhan. It was in the chat just about providing links to the data sets, but I'm sure, Holly, are we okay? Are we able to get a copy of your slides?
For sure, yeah. I'll take off some of the pictures. It's like gigantic. I'll take off some of the pictures and stuff like that so that you get the meat and potatoes in there of the links and whatnot.
Awesome.
Yeah, I mean, one of the things that the REB is in this great position right now because like there was no data governance framework before Dare and Mike Cost did all this incredible work and stuff like that. There were no hands to shake. There was no right to participate office. There was no this, there was no that. So we now, and research quality is now built out in this really wonderful way. So we can shake hands with all of these things. We don't have to do that governance work. We don't have to figure out all these things. So I think we have a nice ecosystem right now at the PHSA that supports research.
Heather, did you see Heather's, Holly?
Yeah, they mentioned the retrospective and prospective studies. We often have a single study that includes both, but that doesn't seem to, there is not a drop down on RISE. Should there be two separate REB applications or combined into one? Jenny?
So the retrospective chart review portion of RISE page A is just purely for retrospective chart reviews. It just makes it easy to submit a quick application that asks all the right questions for a waiver of consent and everything you need to know about a retrospective chart review. If you're going to do both, there isn't a way to combine those two applications. So you just have to use the regular RISE application and indicate that you're doing both retrospective and prospective data collection. And there are questions that will truncate the form for retrospective or not. So it'll pick that up in the application and you'll just have to fill out the entire thing for both.
Any other questions or worries or concerns?
Oh, if that's it. Thank you so much. Thank you, Holly. And also, I just want to flag for everyone that Jenny's taking this call from her vacation in Mexico. So we have a very dedicated research ethics board. So thank you very much, Holly, Jenny.
Oh,
and
there's one
Talisa.
more.
Oh,
There's
yes.
one more here. Remote consenting. If remote consenting, if the method of consent isn't specified, can it be done via Zoom or phone, or does it always need an RFA or amendment? first of all, before I lose my train of thought on this, we are developing, even for Health Canada regulated studies, the most stringent things, ways of doing remote virtual consent. When you like some of these studies now, you're never going to actually interact with them. It's just fully virtual. And so our research quality people have helped to develop a really nice method that actually meets, we think it's going to meet Health Canada requirements around that. There's also the clinical trial management system way of e-consent that is Health Canada compliant. And then for everything else, I think the Red Campus team is looking into some exciting opportunities. But for this question specifically, if the method of consent isn't specified, if it's done by a Zoom or phone, do we need an RFA or amendment? Jenny?
We always want the RISE application to be as specific as possible. So if it doesn't explicitly say how you're doing consent, then it's a quick amendment, and it's something that I can probably approve if there's a time crunch, if you want to switch to remote consenting. The REB cares more about the consent process. So that's the information that we really want in there is how you're going to interact with the participants. Is there going to be an opportunity to have a discussion with them? How are they going to view the consent form? And it's more the interaction that we need to know about. So make sure that's in the RISE application. Everything else is just, quick details that you can put in there. And if it's not there, just update it. It's easy.
And if you're doing a study where you think there might be multiple ways that you would be doing it, then just put them in there, like instead of having to amend later. And like realistically, don't just throw everything in the kitchen sink at us. Like if you really think that you're dealing with the kind of study where you're going to have some people that might come in and some people that might not, then have a justification in there. It's a way to kind of future proof yourself. There's another question here too. I'm wondering about remote consenting for case report. This is for publication purpose, and REB does not review these case reports. So that's the case report process. There's a process that was established in the ethics office under Dr. Alice Barani. The materials are now available. If anyone needs to link to that, I can send you that link just to how that's done. I don't see why. I don't want to get into Alice's business at the ethics office because it's not research. So it's following different aspects of the privacy law and stuff like that. I would send that question to Alice Barani to make sure that remote consenting for those case reports, if there isn't any specific issues around it, because in those cases, they will be hanging on the privacy law way of consenting properly. It's not going to be the norms of Tri-Council policy statement. It'll be how to consent properly under the privacy law. So I would send that to Dr. Alice Barani, that question, or ask me and I'll loop in Alice. I don't want to give you the wrong answer. Oh, thank you. You're welcome.
Hey, and that is all the questions. Thank you so much, everyone. Thank you for joining us this afternoon. Thank you so much, Holly, Jenny, and Lisa. We hope to have you back soon. This was a lot of excitement around this presentation. So thank you very much for sharing your expertise with us.
We've received a few notes about just having you back at a semi-regular cadence, if that's okay. I think just proximity to you folks is just so helpful, and everyone seems very grateful. Thank you so much.
We would love that. We would love that. And also, please, when we send you the survey, I promise you it's 3 minutes. Please fill it out, because not everyone can come to one of these things. Not everyone can meet with us when we meet with folks, on our daily, as part of our daily practice. So, please, that's a way to get a wide, you're researchers. I can't just listen to outliers. I need to hear from everybody. So when we send you out that email, please do it.
Absolutely, we will. Thanks, Holly. And just to flag for everyone else on the call, the next Lunch and Learn is March 19th, and it is part 2 of our qualitative research series. So please join us for that. Thank you
so much for having us.
Thank you. Have a wonderful day, everyone.